First. Someone just sent a message. What's happening in the chat? I missed it already. All right. So GU and renal. Too much enthusiasm. Genito. Generally.
Well, we have Darlene, Armijos, and Casey here as well.
Okay, that's fine. Oh, good news. It'll be on YouTube by the end of the day, hopefully, and catch up. So, genital organs and reproductive system is usually what genito refers to, right? In case we need a quick refresher from BLS and medical terminology. And urinary is the removal of metabolic wastes by the kidneys, okay? So the kidneys do a really good job of making sure that your body is in that kind of good zone, right? We talk about homeostasis and we're achieving this very, very tight area that the body needs to be in, not only with pH, but with waste products and water and all those other things, right? A lot of the times they talk about, oh, well, you're going to die from starvation. You will die from dehydration within 3 days. You will die from starvation like months, okay? You won't be happy. You'll be grumpy and probably really hungry, but you will absolutely positively die from dehydration way, way, way before you die from starvation. So your kidneys and your urinary system do a really good job of making sure that your body's in that homeostasis spot. So it does that through regulating your water and electrolytes, right? This is why we see patients who are on dialysis have issues with electrolytes, particularly potassium, okay? It helps regulate the acid-base balance. The only problem with the acid-base balance is that the kidneys secrete bicarbonate, and that bicarbonate is a very slow regulator of your acid-base balance. So that's more of a long-term fix than your respiratory, which is a fast-term fix. Waste products and foreign chemicals get secreted, right? There's a number of medications as well that you might be taking for chronic conditions that get excreted through the kidneys. They help control your blood pressure. All right, so patients who have kind of uncontrollable blood pressure, a lot of the times what they'll do is they'll do what's called a kidney duplex, and they will, let me see if I get my doodler to work here. Come on, thank you. These renal arteries right here, whoa, yellow, ew. These renal arteries right here and here. Your body can have, just like in your, in your, what's the word I'm looking for? In your heart, right? You have that vessel. And as you get older, that plaque builds up and makes the lumen of this vessel smaller and smaller and starts to restrict blood flow until you can have a full occlusion. Same thing can happen in your renal arteries, except the problem is as the blood flow to your kidneys gets less and less, your kidneys think that you're dying, okay? Your kidneys don't know that it's just like a restrictive issue. They think that your blood pressure is too low to get blood to them, right? Patients who have a blood pressure less than 50 usually end up having a very, very poor prognosis, okay, when they're in a shock state. Because the kidneys shut down. The kidneys are like, what's going on? So what the kidneys do is they start secreting or excreting ADH, antidiuretic hormone. Mercy. All right. ADH, okay, and that ADH starts to increase your blood pressure. Okay, so patients who have uncontrollable blood pressure, they'll come in here and they'll check what these arteries are doing to make sure that there's no plaque buildup in there that's restricting blood flow to the kidneys and falsely elevating their blood pressure. Okay. They also help in the production of red blood cells by secreting various hormones that secreting various hormones that will help create those red blood cells, and glucose production, right? They cortisol and such is secreted, and they participate in blood sugar. So cholera. So renal diseases. Your kidneys live in your retroperitoneal area, right? So this is behind the abdomen. They're in their own little like area, okay? Um, they live, they're about the size of a fist. So if you make a fist, that's about the size of your kidney, okay? You've got two. You only need one, right? You have one for duplicity, just in case. Um, and they are just underneath that 12th rib, okay? So they are protected by the rib cage to a certain extent. Um, the nephron is the basic unit within the kidney. Okay, that is like, the alveoli is the functional unit in the lung. The nephron is the functional unit in the kidney. It filters blood and it helps remove waste products that thereby produce urine. I'm having a mouth problem today. So there are three different problems, or three different reasons that patients can go into renal failure. Okay, it's pre-renal, intrarenal, or post-renal. Most commonly, in the acute care setting, we will see pre-renal. Okay, pre-renal is that there is some sort of hypoperfusion. Okay, that patient could be septic. That patient could be having a traumatic injury and they're hypovolemic. Okay, they could be dehydrated. They could have a number of issues that blood is not getting to the kidneys. Okay. Two, you have intrarenal disease or intrarenal issues, which is usually disease or damage to the kidney itself. So those patients who have chronic renal failure because their kidneys have starting to shut down, right, because of kidney disease, your end stage dialysis patients, bad diabetics, okay, or if someone has actually taken like a direct hit to the kidney where the kidney has a contusion or some other issue that is cause damage to the kidney itself. And then you have post-renal. Post-renal is like there's a blockage. So that could be most of the time is kind of seen in a kidney stone or in men prostate problems. Okay, there's a blockage. There's some sort of reason that urine can't flow and it starts to back up and cause damage to the kidneys. So if you have a patient who is experiencing an acute kidney injury, this is basically because that there is some sort of acute significant decrease in the filtration, okay? It could be that there's low blood supply to the kidneys. It could any number of different things. But the problem with this is that the toxins start to build up. We've hit the point where I start yawning. Most of the time, acute kidney injuries are reversible if treated early, and that treatment a lot of the time can be as simple as hydrating your patient. Okay, there's two different types of acute kidney injury. There's oliguric, oli being a lack of, so they're not making or they're not making as much urine, so they're usually about less than 500 milliliters of urine a day. And then non-oliguric, where they're making more than 500 milliliters a day. So acute kidney injury can happen relatively quickly, okay? If a patient hits anuria, which is a complete lack of urine, that's very troublesome. But as you see here in their little flow chart, a lot of the times it's easily managed with IV fluids, okay? And it's also, hey, we need to do a little investigation and see why the patient needs hydration, right? Is it because they're septic? Is it because they're dehydrated? Is there some other underlying cause, like an infection or something that needs to be investigated, checked out, and such like that? The problem is that patients, when they hold on to that urea, that becomes very dangerous to them. It's very toxic to the brain. You'll see patients who are on long-term dialysis will actually start excreting urea through the skin. We have what's called like a ureic frost, and that's a little bit later in this lecture. So these patients might also be taking medications that are nephrotoxic, such as NSAIDs or other diuretics, right? So if you have a patient who's taking like Lasix and they're like, yo, I'm not making urine anymore, that's a problem, okay? Especially if they're still taking the Lasix. Uremia is too much uric acid in the blood, right? Emia being blood. Most of the time, it's just kind of like the patient will have this generalized edema to their body. They'll look very kind of soft and squishy and edemous because their body isn't able to excrete that excess water and thereby excess salt. Because remember, where water goes, salt goes. And by salt, we mean not only just sodium, but also some other electrolytes. Um, your kidneys also do a really good job removing those acids, right? On top of your body having a respiratory compensation for acids, right? Where you breathe extra heavy to blow off acid. Your kidneys do a lot of that, right? They'll pull it out and they'll dump it into the urine. Other nitrogens start to build up, creatinine, um, any sort of end product of metabolism that might be floating around, especially if you have patients who were, exercising. They might have protein molecules and such in their blood that is going to cause issues with their kidneys. Um, they're important. We like your kidneys. Kidneys are helpful. If uremia is not recognized early, that renal dysfunction, that acute kidney injury, can cause all sorts of problems with the heart, especially because of fluid and volume overload, right? Heart's going to work extra hard to pump all that extra fluidy water blood around. Hyperkalemia, right? Too much potassium, where that body is you have increased risk of having going into VFib, and metabolic acidosis. Okay, very similar to what we see, at least with the hyperkalemia and metabolic acidosis in DKA, right? And DKA involves the kidneys as well as those diabetes. Sure. How did I end up on it? There we go. So we talked about this a little bit already, right? Your three different reasons for a kidney injury. So you might have hypovolemia, um, which might be due to heart failure or other impaired cardiac output, obstruction of renal arteries, which I also talked about, and then either dehydration or overdiuresis. So patients who are, right, those dialysis patients, if they've been overdiuresed, or patients who are taking Lasix and have taken too much, and their body is now on the dehydrated side or the dry side. Intrarenal, those intrinsic kidney diseases could be caused by high blood pressure, um, diabetes that's punching holes in the kidneys, autoimmune problems, all sorts of different issues, toxins. And then post-renal, which is usually due to kidney stones, prostate enlargement. All right, so chronic kidney failure is as this starts to progress, okay? Um, some patients just have congenital issues, okay, congenital kidney issues like kidney diseases. There could be autoimmune, um, pyelonephritis, which is water. Pyelonephritis is inflammation of the kidney. If that isn't resolved, the kidney will start to experience damage. And high blood pressure. High blood pressure and diabetes do a huge amount of damage into your kidneys. So your kidneys are pretty much receiving arterial powered blood, right? So as that arterial powered blood starts getting pushed through, it can start to create problems in those nephrons, right? Because they're they're not protected. They're just getting hit with that high pulsation wave. So as that pressure goes higher and higher, you're going to cause problems. It's like punching a hole in like a window screen. Okay, if the nephron is like a window screen, it's starting to catch all of the toxins, and water should be flowing through easily. But if you're, you know, blowing these, toxins through at high rates of speed, it's going to cause damage. And some of those toxins include glucose, right? Glucose is a very large molecule. So patients who have poorly controlled diabetes, that glucose molecule is going to start beating up the inside of those very delicate parts of the kidney. Um, if a patient has a long-term chronic issue, they might require dialysis once their urine output um, starts to decrease, or if their urine concentration starts to decrease, okay, because there's two different reasons. If their kidneys aren't working at all, they definitely need dialysis. If their kidneys are doing a really poor job, they're going to often need dialysis. And then some of these patients will require transplant. Kidney transplants are the #1 transplanted organ in the United States. Kind of put that into perspective. There's a reason for that, right? It's not just, genital kidney diseases. There's a lot of chronic kidney failure because of high blood pressure and diabetes, which is very prevalent in this country. Here's some stuff. Fluid and waste products, azotemia and uremia. At what GFR percent? I don't honestly know. I think it's different based on, if we go back to here, I think it depends on if you have two kidneys, how much urine output you're making, and what the concentration of it is, and if you have any other comorbidities. Um, I really am not sure. I'm going to say probably somewhere around the stage 3A, 3. But again, I think it depends on a lot of different factors. And probably people's insurance a little bit, because Lord knows that's apparently how we make decisions in this country. So, um, chronic kidney failure now, because you're not able to filter your blood properly, you start to lose a lot of other problems. You create other problems as well. So not only hypertension, because now your body can't filter blood properly, and your kidneys are like, oh, I need to filter more, and starts to call for more blood, increasing blood pressure. You can end up with heart failure due to volume overload, anemia because of blood loss in the kidney itself, as well as electrolyte abnormalities. Electrolyte abnormalities is probably the most dangerous aspect of kidney failure, because that will put people into cardiac dysrhythmias, um, and that's a problem. Hold on, I've unplugged my phone. Cardiac dysrhythmias will kill you way faster than some chronic kidney disease. All right. Some of the signs and symptoms that you might see with chronic kidney failure, GI, right? You have patients who have a loss of appetite, nausea, vomiting, right? Because their body's trying to get rid of some of those acids, and waste products in other ways. Um, Cardiac, high blood pressure. They might have a heart attack or a cardiac infarction. Uh, Pericarditis, pulmonary edema, especially if they're fluid or volume overloaded, peripheral edema. That fluid overload, right, can cause a lot of issues. A lot of potential nervous issues because of that buildup of waste product. I've seen patients full-blown AMS with signs and symptoms of a stroke that ended up being either kidney or liver issues. Those two kind of show very similar nervous system signs. Endocrine, right? Glucose intolerance, right? The patient's not going to be able to tolerate sugar well, because their body can't really manage it. It's going to do more damage to their kidneys. Might have fatigue, confusion, and their skin is usually a good indicator of what their kidney health is, right? That uremic frost, it's like this kind of like white, like kind of dust over somebody's skin, is the body trying to get rid of that uric acid. It goes through the skin, and it comes to this like crystallized frost on their skin. Also, you'll see patients who have that what's called protein wasting. They'll have very thin extremities and kind of a larger middle, because their body is trying to support itself nutritionally and starts to waste the muscles. Number of different things. One, patients who have chronic kidney disease tend to be good candidates for a kidney transplant. A lot of them will usually get from a family member, because the family member will hopefully have a matching kidney. You can survive with one kidney. But the problem with that is they still need to be healthy enough to actually survive the surgery. So that might be delayed for a period of time if they're dealing with anything else, or they're somehow unstable. Hemodialysis is very popular. Or a number of you have probably done the renal shuffle, bringing patients to dialysis. It's usually a 4 to 6 hour process where they sit on a machine and their entire blood content is filtered through a machine. Problems that you often see at hemodialysis, we're going to talk about a little bit, in terms of actual medical problems, but in terms of weirdness, I've seen times when people, okay, I've seen people who, they've trying to clean the port and been injected with bleach instead of the saline. So a lot of weirdness can happen at a hemodialysis center. The other one is peritoneal dialysis. I actually have transported a patient who did her own peritoneal dialysis at home. There's these big old jugs, and it puts it basically has like these two ports in her abdomen. So she at night when she goes to bed, she hooks up one side and holds it has like a IV pole over the bed. It puts all the fluid into her abdomen. And then there's another big same size jug that she's connected to on the other side of her abdomen that collects everything. And the fluid that they put into the peritoneal cavity actually pulls a lot of the waste products out um, through the abdominal wall, like all those capillaries and blood. Because remember, your abdomen's very vascular, and then removes it from the other side. You don't I don't think you see peritoneal dialysis quite as frequently as you do hemodialysis. Here's how hemodialysis works. They take the blood out, it goes through what's called a dialyzer, okay? It filters the waste products and any other extra fluid, okay? And then it has clean blood that returns. Patients who are on hemodialysis, you should ask them a few really important questions when you are doing your assessment. One of them is, when was your last dialysis appointment? Have you missed any dialysis appointments? Did they take off the same amount of fluid? What was your beginning and end weight for dialysis? Have you ever had issues with, dialysis before? Is this a similar issue? So patients who are just starting dialysis will end up having a lot of, will potentially have a number of issues called disequilibrium issues, because their body's not used to that massive draw of waste products and electrolytes coming off. So they kind of feel funky for a little bit. They have like um, headache, dizziness, nausea, AMS, a lot of like things that like you're like, what's going on? And it's usually within a few hours after complete dialysis, and their body's like, whoa, bro, that was a lot. Okay. Um, Dialysis patients, they either will have an AV fistula, which I'm sure everyone's kind of familiar with, where they surgically go in and they take a artery in the arm and connect it straight to a vein. So it bypasses that capillary bed and the pressure starts to cause it to dilate. Those are very commonly a concern in trauma. Patients who hit their fistula and rip it open by accident, they bleed a lot. Okay, there's nothing there slowing that down. Also, there's a possibility of that fistula clotting if these patients, if that blood stagnates in that fistula. I've seen that before also, where that whole artery vein um, combination just becomes a giant blood clot. A lot of patients they have chest ports now. They just have the ports right directly in the chest, which is a little safer because there's a little less risk of bleeding, an AV fistula problem. So here's peritoneal dialysis. Okay, so the fluid goes in, goes back out, and from the catheter, and in the drainage is really where they see all that waste product. So it kind of goes through and it soaks up it creates a gradient, right? Your body really functions on gradients, and as it pulls the waste products and the electrolytes and acids and such out, it gets dumped into the drainage bag. So we talked about some of this already a little bit, but we're going to go a little bit more in depth now. So dialysis emergencies are common. So it could be due to the fact that the patient has some sort of disease process going on, right? So if you have a dialysis patient who is then involved in a significant trauma, okay, their body's not going to be able to tolerate it as well as a regular person. Okay, they're not going to be able to maybe secrete as much cortisol, your stress hormone, or they're not going to be able to shift, blood to where they needs to potentially be. They also are dealing with an altered metabolism. So if you have somebody who, excuse me, is a dialysis patient and we go into cardiac arrest, they could already be more acidic than your standard person because of that lack of um, hemostasis. Um, so you want to make sure that those patients are you recognize those patients. Okay, you even look in your protocols, your medical control options in cardiac arrest include going straight to sodium bicarb and calcium in a patient who is a dialysis patient because they're going to be more acidic. Acidic body does not respond well to cardiac arrest or cardiac arrest meds. Epinephrine is acidic. So if you're already starting at being more acidic and you make it worse, patient's not going to come back. So we want to, kind of front load the bicarb buffer to see if you have a positive outcome. Other complications, right, and potentially unpredictable actions of drugs. Patient might have a lot of different things that they're told that they should or should not take. I know a lot of dialysis patients that they get a list of foods they should be avoiding. For example, while you would think a banana is very high in potassium, cantaloupe is actually the highest potassium of rate of fruits. So you're a bad dialysis patient, you can just go eat like a cantaloupe and kill yourself because of potassium. Inadvertently, they could be overloaded by IV fluids. More commonly, you see that they take too much off in dialysis and the patient feels kind of crappy, a little on the dehydrated side. Might be a little tachycardic because their body's like, whoa, we don't have enough fluid. Um, Vascular site problems, right? You have this fistula, you have this wild, enormous vein problem going on, right? That could bleed. That happens a lot if it doesn't clot properly. They usually won't let them go home from the dialysis center if it hasn't finished clotting. But there's plenty of people who kind of rush that whole process along. This site can also thrombose, right? So you can have a huge clot in there. Infection is always a possibility, especially if you have people who don't have, they don't practice good hygiene. And then you could have what's called a pseudoaneurysm, right? So that heart might come up and bubble and burst because of issues with pressure. So a lot of the times they don't want you to use a tourniquet on patients who have a AV fistula because it will cause damage and long-term damage to the fistula. But if it's life or limb, that patient's losing lots and lots of blood, oh well, they're getting it. One thing I will say, which is kind of wild, the best bleeding control I've ever seen for an AV fistula was a paper towel. We use some of the problems that we have when we have use the bandages that we do, right? You can put a trauma bandage on it, right? The problem with trauma bandages is that it can wick extra blood up. So even though you're putting pressure on it, like there's still space in that bandage for the blood to kind of go, even though you don't necessarily notice it. Um, so something thin like a paper towel, like there's no space for it to wick. It just has to clot. Um, Platelets start to work not as great during dialysis because of all the other, kind of acid base imbalances going on. These patients are going to be getting anticoagulants regularly. They get heparin injections into either their port or their fistula at the end of the treatment because they want to make sure that the whole thing doesn't become giant thrombosis. And any trauma to the fistula is also obviously a concern. So dialysis is supposed to kind of be over a period of time. However, there's a huge issue when it comes to some patients who aren't necessarily really good at managing their fluid regular. So all of a sudden they might have this huge reduction in intravascular volume and this huge change in electrolyte concentrations. So not only are you reducing their blood pressure potentially significantly, but you're also reducing the electrolytes. So patients, if we talked about this already, that disequilibrium where patients don't feel good. It also can cause vascular instability because the heart is sensitive to all of those electrolytes. Okay, so if you start changing the electrolytes rapidly, the heart, they might have different cardiac abnormalities. Chest pain is very, very common in dialysis patients. Well, most of the time it could be very very much attributed to the fact that they are having a fluid shift as well as an electrolyte shift and a blood pressure decrease. It could also be that they're maybe a little hypoxic, um, which can lead to an MI and chest pain. It could be that, now they're having a dysrhythmia, right? So you've now taken all of the extra sodium off, and maybe the patient's going into a VTAC possibility. Okay, all this you have to be particularly careful with dialysis patients because their electrolytes could be doing something completely funky. So you want to make sure that you actually look. It's just arrhythmias are going to be terrible. The fluid leaving the vascular system is going into the dialysis machine, so it's leaving the body entirely. It's not even like third spacing. It's not going to like the interstitial spaces or anything. It's just being physically removed. Um, so like imagine like giving a pint of blood, right? Imagine how you feel after you give blood. You kind of feel a little dizzy, maybe a little woozy, right? Because you're missing like a significant amount of blood. That's a pint. But now imagine it's just the fluid, just the waste products. Yeah, you got new, shiny, clean blood, but your plasma level is reduced. So that means that you have an increased red blood cell count, right? So all of those products that are floating around in your blood are now closer together because there's not as much fluid spacing them out. So you have an increased risk of clotting for that as well. That's why they also be sure that they give these patients heparin, because if you're taking that fluid and you're just taking the plasma right out. So we talked about this a little bit during um, endocrine, right, with DKA. This is what the DKA looks like on a 12 lead. Okay, so see you have this, let me see if doodle. All right. So see how you have this widening of the bar. Here's widening of the QRS, right? It's starting to look like if you looked at this and you didn't look at, the T waves, you'd be like, wow, look at that. It's like a bundle branch block. Okay. Until you look at the T waves. Look at the T wave. Look how pointy that is. Okay. T waves should be kind of roundish. Okay. So if it was, if this happened to be a left bundle branch block, you wouldn't expect the T wave to be not only so pointy but so big. Look at in comparison. Ready? You have here's your QRS. Your T wave is almost the same size as it. If your T wave is almost the same size as your QRS, you should be highly suspicious of hyperkalemia. Okay, that's a K problem. That's a potassium issue right there. So your potassium usually is, I believe it's 4.5. Oh, goodbye, doodler. Is usually like 4 to, I think it's 4.5 to like 6.4 ish, maybe even lower. The actual numbers. Um, Sorry, 3.6 to 5.2. It's close. Never take a 1. Once the potassium starts to get over 6.5, very bad, very, very bad. You're going to start seeing EKG changes. The patient's going to be not feeling good. They're going to be altered mental status, and they will potentially drop into cardiac arrest, VFib rapidly. Okay. Um, Usually it's because they've either missed dialysis or they're not watching what they eat. A lot of people, that seems to be people's issues. I don't want to watch what I'm eating. I want to eat what I want to eat. Okay, but do you want to die? Because, it's one or the other. Um, I will say if you do happen to pick up patients who have quote unquote abnormal labs, um, I've seen this a couple times, and I actually was on my rotations as in paramedic school. The patient came in to the ER because they told her that she had a potassium of 10. And the doctor looked at her and said, well, a potassium of 10 is incompatible with life, so we're going to rerun your bloods, but I don't think you're dying. I was like, oh, that's... So basically, right, when you get your bloods drawn, the potassium's inside the cells, bounce that blood around, the potassium leaks out of the cells because you busted all the cells open. So it's going to give you a falsely high potassium in that little 2.5 milliliter tube. So if you have somebody who has a potassium of 10, probably, if they're awake and talking to you, they don't have a potassium of 10. High potassium foods. Okay. Cantaloupe, right, can be extremely deadly. I saw something just pop up real quick and then go away on the chat. A lot of different things. And this is the hardest part of dialysis or for kidney failure for people is really watching what they eat. There's a lot of different things that can really skew their potassium levels. Um, and it's like everywhere, like potatoes. Potatoes are everywhere, right? You think, hey, I'm gonna make a quick little meal. Let me make some pasta and sauce, and you crack open a thing of spaghetti sauce. Ooh, you've done messed up your day, right? So this is usually where we see people start to have issues, okay? Um, and this is part of the reason also you'll see where people don't get transplants because they won't take care of themselves. If they don't commit to taking care of themselves, they usually knock themselves pretty far down onto the transplant list. Um, so we talked about this already. Um, Neurological findings that usually happen right after dialysis. It could be um, a few hours to maybe a day, especially when you have patients who are new to dialysis. They might be having some nausea, fatigue. They might end up all the way having seizures, right? Because now all of a sudden they have this massive gradient shift because they've taken all that waste product off. The body has kind of because by the time, this chronic kidney disease is caught, the body's kind of started to accommodate itself to like new levels of crap in the blood, right? New levels of fluid. Sort of like the hypoxic drive, right? So your body's like, ah, well, my carbon dioxide sensitivity doesn't work anymore. Let's switch to oxygen. Same thing kind of happens with your kidneys, where your body's like, wow, yeah, it's a lot of stuff floating around. Good stuff. I don't like this at all. All right, you know what? We're just gonna pretend this is normal, and we're just gonna kind of, climatize ourselves to this, and then all of a sudden you dialyze this patient. They're like, whoa. The body's like, wait a minute, it's so fresh and clean. It smells like lemons. Why? I don't understand. Um, and then you can have all sorts of like neurological findings. Okay. And it could be something relatively benign, like some nausea and fatigue, to full-blown tonic-clonic seizures. You should make sure that when you're doing your patient assessment that you ask about this patient's, dialysis history, kidney history, especially if they're like, well, they've never had seizures before, right? Well, what's new? What has changed in their medical history? Air embolisms are always a possibility when dialysis tubing might have a malfunction. Okay, if you have anybody who has a sudden onset, especially while at dialysis, sudden onset of severe dyspnea and hypotension, cyanosis, right? All of a sudden they look like crap, and you're like, what's going on? Very strong possibilities in air embolism. You want to make sure that those patients are transported left lateral recumbent, right? Because you want to make sure that that air embolism doesn't get to the brain. Okay, so if the air embolism has gotten to the brain, they might also not just present with cyanosis or hypotension. They might present with like stroke-like symptoms. So keep that in mind. That's your bladder down there in the bottom. Urinary system. Um, Urinary retention is more common in men most of the time due to the prostate doing prostatey things. BPH, benign prostate hyperplasia, is completely a kind of, unfortunately, a run-of-the-mill standard male problem. Happens as men get older. Not necessarily normal, but it's pretty, common. Usually they treat that with Flomax to kind of dilate that urethra. But it whatever is causing you to not be able to completely void urine. So it could be medications, it could be obstruction due to a stone, it could be the prostate, it could be due to a neural problem, right? Patients who have paralysis, right, might not be able to fully empty their bladder, or they might have to straight cath themselves in order to actually void. So there's a lot of different concerns. Basically, if the patient is complaining of severe abdominal pain with a need to urinate, but are unable to, you might be able to actually palpate their bladder. Um, I want to say, can't remember exactly how much. I want to say the bladder can hold about 500 milliliters of fluid, but it can stretch also. There is a part on the back of the bladder. It's shaped like a triangle, triangle, triangle. Um, when that starts to stretch, that's usually when your body's like, "Excuse me, it is time to go to the bathroom." Okay, that's kind of like your inhibiting area. So if you end up with this bladder that's getting really, really swollen, the patient's going to be in a bit of distress, especially if they are unable to void. Um, so they also might complain of an incomplete emptying, peeing frequently at night. A lot of this you see with the patients who have the prostate issues. Um, the problem with urinary retention as well, beyond the possibility of a ruptured bladder, is infection. Okay, so and kidney damage, because as that bladder starts to become too full, that fluid's going to back up and up and up the ureters back to the kidneys, and it's going to cause something called hydronephrosis. Hydronephrosis is water on the kidney. Okay, not good. Reversible, but not good for your kidney. But UTIs are a problem. UTIs may or may not be like, you might have symptoms, might not have symptoms. So a patient might have something like painful urination or increased urinary frequency. But a lot of the times especially in women, especially women who've had like frequent UTIs, they might not notice it. And it might only show up on like a dipstick test or urinalysis. The problem is, as those UTIs become worse, they start to travel upwards. It can lead to a kidney infection, which is challenging to treat, and can have severe flank pain and very high fever, or can lead to sepsis overall. One call that I will say I was absolutely boggled my mind. There was a lady who had been recently discharged from a long stay at the hospital due to a kidney infection, and they had put in, you know how you have like the colostomy bags, they put in a urostomy bag. So there was this little tube coming directly out from her kidney and into about a 250 milliliter bag that she had kind of strapped to her side, and she was completely altered, was not responding, hot to the touch, already like you walked in, you knew she was sick. So her son was saying, yeah, went to her urologist yesterday. The guy said she was fine, that they were going to talk about taking the urostomy bag out in like a week or so. Her urostomy bag was completely full of pus. So I don't know what this doctor was looking at, but it was no urine. It was pure pus. Um, so let's just talk about how that can go sideways quickly. But she was very, very sick. Um, Obviously, if the patient doesn't have a urostomy bag, it's not necessarily something you're going to be able to visualize. But just keep that in mind, that these things can get very bad very fast. It can very quickly lead to sepsis. So we talk about the common signs of urinary tract infection, right? Dark and cloudy urine, um, painful urination, frequent urination. If the urine doesn't look clear, right? Cloudy urine. Um, Anything that might pop up in like, like, it just looks not good, right? Any sort of flank pain, right? So it's going to come down the side. It could also radiate into like the middle of the body, right? So it's not necessarily just going to be flank. It could be like, periumbilical pain or lower, especially suprapubic, right? Just above that pubic bone. Urine could smell bad. So pyelonephritis is an inflammation, usually due to an infection in the kidney. Okay, so now all those little nephrons are infected, and the kidney's not doing what it needs to do. It usually is due to backflow, right? So that there's some sort of blockage in, the ureter, the kidney stone, prostate, right? Urinary retention leads back up. So everything that's kind of sitting there in that kidney starts to kind of ferment, right? And the bacteria has the ability to grow, because bacteria likes stagnated mediums in which to grow, like urine. Like, just think about like mosquitoes, right? You leave standing water, mosquitoes come to it. If you leave standing urine, bacteria is going to start growing. Um, Lower back pain, flank pain, nausea, vomiting, very similar in um, presentation to a UTI. The pain might just be a little bit higher in the back, and the patient might look overall more sick. The problem with pyelonephritis is if it's untreated or if it's left for a period of time, it will do pretty significant damage. Kidney stones. Get the picture. I do. Kidney stones have a very specific area in which they kind of live in the United States, which is kind of branching out a little bit now. Most of the time, it's due to the accumulation of insoluble salts and uric acid inside the kidney. This is usually due to not hydrating well enough. As you see here, this is called the kidney stone belt. Most of the you see is in that lower southeastern region where people drink sweet tea and are in a hot environment. So they're sweating, and black tea actually has a component in it that promotes the development of kidney stones. So you'll see a lot of kidney stones in this particular area. Um, there's a lot of other issues that can lead to kidney stones. They could just idiosyncratically form where patients are like, I don't know, I have no history, but boom, kidney stone. So herbal medications that patients or people might take can promote the development of them, surgery, anything again where like the kidney's not necessarily operating 100% or is oversaturated with salts. The epididymis. Okay, so gentlemen, you get a few slides on problems. You don't get a whole lecture, but you get a few slides on your male man problems. So the epididymis is that pathway, there you go, in which the sperm leaves the testicle into the seminal vesicles. Okay, a lot of times if this becomes inflamed, it's due to a bacterial infection, usually brought on by an STD such as gonorrhea or chlamydia, though that does not mean that, something else in the area such as a UTI could not also, contribute to epididymis. Nope. So you might have a patient who, is very swollen testicles, red, hot to the touch. Not that you're going to necessarily be touching them, but they'll probably tell you. Right? So any itis is an inflammation. Okay, so epididymitis, but there's nothing saying that hey, this isn't a testicular torsion. Okay, so you want to make sure that you still maintain a high level of suspicion. Fournier gangrene. This is a bacterial infection of the scrotum. Can happen in men and women, more common in men. Most of the time, there's secondary complications such as obesity, diabetes. There's a wound or some sort of abrasion that becomes infected, and because of the location, isn't necessarily picked up on. Okay, very not good. Increased pain and tenderness. This is obviously the gangrene because of the type of bacteria it is that infects it is causing all sorts of death to the tissue. Um, Phimosis and paraphimosis. This is usually seen in gentlemen who are still working with the foreskin. Um, Phimosis is they're unable to move the foreskin back. It's usually due to some level of inflammation, so they are unable to expose the head of the penis. Usually not too bad, not a big deal. They'll kind of go in and fix it. But the bigger problem is paraphimosis. They have pulled the foreskin back and they can't move it forward. And what happens is it starts to reduce the blood flow to the head of the penis, which may cause, obviously, death and destruction to that tissue. And the head, there's a donut, right? Swollen skin near the head of the penis, which is where the blood flow is being restricted. Okay, both of these things are again seen with men who are still have a foreskin intact. Most of the time, this is seen in small infants when first-time parents, mom and dad, don't necessarily know how to clean that area properly, and bacteria kind of grows, especially in the moist environment of a diaper. Remember, bacteria like moist areas. Priapism. Oh, number of problems associated with priapism, right? More than 4 hours. If your erection lasts for more than 4 hours, most of the time this is due to a spinal cord injury, so you need to make sure that that's taken into account. And they will, in fact, drain this. And every single nurse in the ER will skip to the bedside to watch a priapism being drained. Um, Low flow is that there's some sort of blood being stuck in those erectile chambers of the penis. High flow is less common and less painful, but usually is due to a ruptured artery, which might be due to a traumatic injury um, inside the penis. We're just going to leave it at that. Benign prostatic hypertrophy. Okay, right. This is usually an older gentleman, 40s and older. The prostate gland just starts to kind of grow. All right, hypertrophy is like you end up with larger cells. Most of the time, it's not due to cancer or anything. It's just those cells are like, hey, we're going to be big today. We're a little brolic. But the problem with having a larger prostate is it starts to crush that poor urethra, and it's harder for men to, with BPH, to then pass urine. Testicular masses, we are not going to go into the specific ones, but if there's a growth on one or both testicles, it could be due to a number of different things. Testicular cancer is on the rise, especially in younger men. So get tested. There you go, males 15 to 34. Um, but the problem, not the problem, the good thing is testicular cancer is extremely survivable if diagnosed early. Gentlemen, you definitely feel up your testicles way more than, women feel up their boobs. So you're probably going to find testicular cancer way before a woman finds breast cancer. And for some reason, everyone loves to take men when their complaints more seriously. So go to the doctor and be like, problem. Also, there's this weird thing that if you have testicular cancer and you pee on a pregnancy stick, if you come back pregnant, there's a very strong possibility that you have testicular cancer and should go see a doctor. Testicular torsion. So we talked about this a little bit in regards to ovarian torsions. It's a lot easier for testicular torsion to happen because, gentlemen, your junk just kind of hangs there. So basically what happens is that testicle starts to twist along the spermatic cord, and as it twists along the spermatic cord, it starts to shut down blood flow. The problem is when that blood flow starts to get shut down, that the testicle may die. It's also easier to see a testicular torsion because there will be redness and swelling to the area. A lot of the times this happens in young kids, okay? A little bit more, room to move, I guess. A lot of times it's spontaneous or occurs during sports, okay? But they will be afebrile and they will all of a sudden have extreme testicular pain. This is a surgical emergency and should be treated as such, okay? This is a note. No ifs, ands, or buts about it. If you have someone who this is their chief complaint, that you should be calling in a note to the hospital and say, hey, testicular torsion, and there'll be a doctor waiting for you. Take off, apparently. All right. Questions, thoughts, concerns. Hold on. Let me see. Nope, that's it. All right. Questions, thoughts, concerns. He's got the face like testicular torsion face. Oh, that was cold. Did I get to see the exam? This most upcoming exam? No, not yet. I will see if we can get a review to you. All right. Any other questions? World is not burning down. Slightly not burning down. Teaching EMT class. Narcan training. Uh, bless this child. He has now done 2 of the incorrect Narcan training. Things. Hold on. All right. Hematology, since no one has it. Blurred. Blurred. Blood is important. We like having blood. It does a lot for the body, but again, every part of your body really does serve an important purpose, and contributes to homeostasis and, making you function. So its chief functions are the delivery of substances that you need for cellular metabolism, so oxygen and glucose. Okay. Defense against invading microorganisms and injury, which obviously white blood cells, they help out in that department, as well as they help move around clotting factors and other factors you need to not like bleed to death from a paper cut. And the maintenance of acid-base balance, right? So your body helps move bicarb around. It helps bring information back to the brainstem and the medulla so that your body can determine if it needs to breathe faster or secrete or excrete other hormones or buffers in order to maintain homeostasis. Your bone marrow is what primarily produces your blood, the components of your blood. Okay. It's in membranous bones, which are your vertebrae, pelvis, sternum, and ribs, your red bone marrow. That's the one that produces your red blood cells, okay? And then you have your yellow bone marrow, which helps produce white blood cells, okay? So the larger the bone, especially in children, right, that becomes red, it's red marrow. They need that overturn in the red blood cells. As you get older, that red, especially in like a femur or a long bone, that's when it becomes more towards doing white blood cell thing. Your spleen, which while you can live without it, not only is a portion of your immune system, it's also a portion of your hematological system. It will actually serve as a storage unit for red blood cells, okay? It also helps produce different white blood cells and antibodies, okay? It's super helpful. If you're going into a shock state because of bleeding, your spleen will start sending out extra blood so you can kind of maintain your blood pressure a little bit longer. It's very, very friendly, very helpful. Your liver, on the other hand, is extremely important, okay? Your liver does a lot for you. It, especially while you're talking about things like clotting and coagulation factors, right? Your liver can only do one thing at a time, though. And this is why alcoholics tend to have bleeding issues. So your liver can either do its normal functions or detoxify you. So if you've got a heavy night of drinking, it's not going to be able to do all the things like create coagulation factors or albumin or any of those other things that it does for the normal basis because it's busy keeping you from dying from alcohol. Okay. And as I said, this is why alcoholics die from like bleeding problems because they'll go hit their head and their liver's like, I'm sorry, I tried, I'm busy getting rid of this alcohol. Anybody else want to pick up on the coagulation factors? And the body's like, yeah, no, that's your job, bro. And that's it. They start to have bad bleeds. The liver starts to form blood for you as a human while in utero. So we're going to start here in red blood cells. Red blood cells are the most common, most abundant formed cell inside of blood. Okay. They last about 120 days. I was going to say something and I probably forgot. Right? So it's about 3 months. 4 months. 4 months for a red blood cell. So your body's constantly making red blood cells. If you ever look at your blood work, there's a part there, it's like the mean corpuscular value. Basically, it looks at your red blood cells in the different sizes because you will have mature and immature red blood cells. And if they're kind of in a good spot, right, you should have a good ratio. That means that your body's still making red blood cells. Your body will break down red blood cells inside of your liver. Macrophages will do it. They kind of, right? They chew them up. And the byproduct of that iron that's attached to red blood cells becomes bilirubin. Okay. And bilirubin is then filtered out by your liver and by your kidneys and just, it leaves the body or is recycled to become new hemoglobin. This is why when you have alcoholics, they start to get jaundice when their liver starts to fail because they can't get rid of that bilirubin. Then we have platelets, also called thrombocytes. They are super helpful in terms of making clots. Okay, they will respond to anywhere in the body and create clots so you don't bleed to death from a paper cut. Platelets also have a relatively short half-life. So this is why we take, like blood thinners and stuff have similar half-lives. Aspirin is good for about 7 days. Platelets last about 14. So you can, if you are on a patient who is on, aspirin regimen, you could kind of take it once a week, but you still have your body making new platelets all the time. So that's why they have you take aspirin every single day. Aspirin sticks to the platelets and makes it less sticky. Then we have plasma, right? Plasma is the lazy river for your blood. Okay, all the blood cells, which actually look like little tubes, right? They all float around in your plasma. The plasma carries a lot of other stuff. So it carries it's mostly water, but it carries um, salts, metals, inorganic compounds. It dissolves carbon dioxide into carbonic acid and be transported back to the lungs. Albumin, which is protein, globulins, also proteins, fibrinogen, which is a compound to help with the clotting. Okay, it does a lot. Okay, we don't think about it that much. Plasma is super important because it is in fact 92% water, though. This is why hydration is so important. Then we have our white blood cells, right? This is part of our immune system. We talked about this already back in immunology. Um, they do a really good job of keeping you healthy. They are usually at a relatively low level of in your system, and they only start to increase in number when you are sick. Homeostasis in regards to bleeding and clotting is important because it kind of keeps you in that balance between life and death. So homeostasis, this process starts when there's a break in the vascular endothelium. Endothelium being the inside of the blood vessel. So your body's like, hey, that's not good. Let's fix that. So the first part of homeostasis in regards to bleeding control or normal bleeding control is that your body will vasoconstrict. Okay, your body basically wants to shut down blood flow to that area so you don't lose too much. It also now slows down the blood flow so components like platelets and your other clotting factors can start to stick to the area that's damaged. Then you have where the platelets start to release fibrin, okay, and it starts to seal that whole component up, right? The clot is formed. Then, as the fibrin starts to get extra sticky, it starts to get the red blood cells in there and it's completely sealed. So you have this like smoother area, okay, of where the damage was, and it can start to heal. Here's one of your pathways, your clotting pathways. So basically, intrinsic is there's some sort of interior damage, okay, where extrinsic is there's some sort of outside tissue injury. You don't need to know all of these things, but you do need to know that calcium pops up a lot. Let me calcium, more calcium. Oh, calcium again. I don't know what the calcium, calcium. Oh my goodness, calcium. It's very important, right? If you have a patient who is hypocalcemic, they're not going to be able to clot very well. Okay, calcium is essential in the clotting process. There's a number of different other components that are involved, and we're going to talk about them relative to how they cause different bleeding disorders. Those are the ones that you're going to need to know, such as Christmas factor. Sounds so festive. It takes about 7 to 10 minutes to form a clot if you are not on blood thinners. If you are on aspirin or other blood thinners, this time may be extended. This is also going to be completely dependent on how large your injury is, okay? Take off a hand, it's going to take a little bit longer to form a clot. Disorders. This is super common, especially amongst women who decide to go and lose a few milliliters of blood every anemia, okay? The concentration of the hemoglobin is lower than normal. It's usually a symptom of another disease, but at the same time, it could be kind of a normal state based on malnutrition, okay? If you're not getting enough iron in the diet. A lot of the time, it's due to acute or chronic blood loss. This is why women tend to be anemic. We have that chronic monthly blood loss. A decreased production of red blood cells or an increased destruction of red blood cells, okay? Cancers, right? Blood cancers tend to break down red blood cells. Endurance runners, okay? When you're doing some sort of endurance athletic feat, okay? Especially running because of the pounding on the ground. The pounding on the ground every time the blood is in your foot when you hit the ground, it actually will break up some red blood cells, so you have an increased destruction of red blood cells. Patients who are at increased risk are your standard run-of-the-mill people who have chronic inflammation, your autoimmune patients, anybody with cancer, heart disease, diabetes, right? People who have comorbidities. Any kind of comorbidity can contribute to anemia. Pernicious anemia is due to a vitamin B12 deficiency. Fun thing that I learned, B12 will actually make your red blood cells quote unquote fluffy. And by fluffy, I mean they're kind of big and floofy looking. Apparently they're a little larger, as told to me by a cardiologist, okay? So if the B12 is not being digested properly, or you're not getting enough B12, your body won't be able to make as many red blood cells, okay? So this is why it's important to get your vegetables, your fruits and veggies. Then you have your iron deficiency anemia. Okay, so iron deficiency, iron is the main component of hemoglobin. Okay, on a red blood cell, you have 4 hemoglobin molecules. Okay, the heme is iron. Just because you have 4 hemoglobin molecules on that red blood cell does not necessarily mean that they're fully saturated with iron. Okay, this is patients who have a kind of like light pink looking blood. They might have hemoglobin, but it might not be fully saturated with iron. When you have less iron, there's less hemoglobin, and you have little itty bitty inefficient red blood cells. Okay, again, you see this a lot in patients who have very specific diets, like vegetarians, right? They might not be getting enough iron. Patients who, or people who, maybe have some other vitamin C deficiencies, your body will absorb iron when it's in the presence of vitamin C. Okay, so those two go together. They work together to make your body be able to use these minerals back. Here are some other fun things that might contribute to anemia. Okay, so any sort of bleeding, certain medications, NSAIDs, blood thinners, patients who have increased iron requirements, your women, just in general, women have a higher iron requirement than men. And then decrease intake of malabsorption. So anybody who has, specific diets or lack of a balanced diet, coffee reduces your the ability to absorb iron. So if anyone is actually supplementing with iron, then they need to make sure that's taken with vitamin C and not taken at the same time as coffee or calcium or other oxalates. Oxalates are found in black tea. Okay, so all of those things kind of contribute. Foods like spinach, right? Spinach, oh, it's higher in iron. Your body doesn't absorb that as well because of the kind of iron that it is. But then there's hemolytic anemia, which is when your body goes, I'm gonna break this red blood cell down. Red blood cells down, like, I'm good, I'm fine. What's wrong with you? And it breaks it down. Most of the time, there is either something wrong with the red blood cell, so the body breaks it down faster than that 120-day period, or there's some sort of like immune disorder or another disease process going on that contributes to a hemolytic anemia. Patients who have hemolytic anemia frequently need blood transfusions until they figure out why the blood's being broken down prematurely. Sometimes it might be because there is an inherited disorder, thalassemia, which is very common European families. Okay, you, instead of having really nice red life raft shaped red blood cells, they're a little more square. Sickle cell, again, it's got that half moon shape. Those can contribute to hemolytic anemia. So there's usually just something wrong with the red blood cell. The body's like, let's break that bad boy down. Other problems like malaria, right? We talked about malaria a little bit already in communicable and infectious diseases. Malaria is a parasite, and that parasite will go and it will pop in to the blood and will start destroying red blood cells. Okay, so these patients will, be really, really sick. They'll show up on a blood smear as having that parasite inside the blood. Other autoimmune disorders can destroy red blood cells, right? If attacking the body, whatever autoimmune disease can decide where it's going to attack depending on where it is. Signs and symptoms of anemia uh, is usually, like, depending on what kind, the patient might have yellowish skin if the red blood cells are being broken down prematurely, because that's that bilirubin floating around. They also might be very pale. Patients who are complaining of being cold all the time, maybe having chest pain. I've seen some patients who they have like a hemoglobin of 1 or something really stupid low, and they're having severe chest pain because their body isn't able to move that oxygen to the heart, which needs it, right? Leg cramps, again, same thing. You have large muscle groups there that are asking for oxygen to function or aren't able to get as much as they need. And fatigue and dizziness is very common as well. So all of these signs and symptoms, might be a sign of anemia. Also, patients might end up with like sores in their mouth from. So you have sickle cell disease. One of my students in my last class thought you caught sickle cell disease. You were born with sickle cell disease. It is inherited. There is a problem with the way that red blood cells are shaped, and instead of being that really nice lifeboat shape, they turn into this weird hook shape, as seen in this picture. It's a sickle. It looks like a hook. Um, the problem with sickle-shaped red blood cells are that, one, they're very fragile and break down, so the patient's going to be potentially anemic. Two, they're not exactly going to flow through a round hole very easily, right? That vasculature is round. They're going to get stuck on all of the little bifurcations and those little turns and stuff and cause pain, especially in the joints, okay? Sickle cell disease patients, especially when they're in a sickle cell crisis, will be having a lot of joint pain, lower back pain, pain in places where, like, you have highly vascular organs, where now you're having these funky shaped blood cells getting stuck. And it can also cause ischemia because now it's clogging up those little vessels, and you're going to have potentially little areas of extreme low oxygen. There's a whole slew of different signs and symptoms associated with sickle cell. Don't apply ice if we have a patient who's complaining of joint pain due to sickle cell, right? This is when it's important to get a good history. Ice will not help. Ice is going to constrict those blood vessels and make it worse. Depending on how frequently they may have a sickle cell crisis or a sickle cell flare-up, they could have significantly delayed growth and development. Priapism is possible, okay, within splenomegaly. We might have patients who don't even have a spleen at all because those sickle cell red blood cells have kind of did significant damage to the spleen. Kidney problem, right? All of your important but very sensitive organs. Stroke. You don't want to have non-round blood cells jamming up spaces in your head. Patients can live pretty comfortably with sickle cell, depending on how badly their disease is. But the problem is if they end up in crisis. And crisis is they are experiencing extreme pain brought on by any sort of stressor, especially things like dehydration, lack of oxygen, extreme exercise, extreme temperatures. Okay, any of those things can make it worse. And then there's different types. Aplastic is when the bone marrow stops making red blood cells. Okay, so they'll potentially be severely anemic because there's no extra. Hemolytic, the red blood cells are breaking down. And then sequestration, where the red blood cells get stuck. Okay, they get stuck in the spleen and cause a lot of left upper quadrant pain. For the most part, we are going to do the oxygen, hydration, and pain management part. The pain management, if you're working in New York City, you will have to call and get request pain management. We do not do electrolyte replacement if we're doing anything over and above normal saline, or if you have a lactated ringers on your truck, you might be able to do a little electrolyte replacement with that. That's a repeat cell. So if you have different types of red blood cells based on different disease processes, but right, they should kind of look like lifesavers. Little guys. Leukemia is a cancer of the white blood cells. It makes way too many white blood cells, usually in the bone marrow, and causes the body isn't able to then make other components. Okay, there's a lot of different leukemias that are out there. It is unfortunately very common in young children. Okay, the acute stage is the cancer cells start to proliferate, whereas a chronic is, mature but not differentiated cells. I do believe leukemia, kind of leukemia it is, patients might be living with it as chronic leukemia, and just doing like various managements to keep it under. So you have acute lymphocytic, okay, which is usually younger children, and then you have, I'm not even trying, acute myelogenetic, which is older adults. Basically, there's just so many white blood cells going on that the vital organs start to become kind of gunked up by it, and then it leads to death because of organ failure. The most common kind of non-crazy sign of leukemia are patients who just have abnormal bleeding. This is why when you go to the dentist, they ask you if your gums are bleeding. Because if you have like just abnormal gum bleeding, it's usually, unfortunately, a sign of other things like a lot of sweating, right? Because it's your white blood cells. Your white blood cells are part of your immune system. Your body's thinking that there's some sort of immune response. So you're going to potentially show signs like elevated temperature, sweating, fatigue, bruising and bleeding, though, or abnormal bruising and bleeding. Weight loss is always not a good sign to cancer, just in general, non-specific cancer. Lymphoma comes in two versions. You have Hodgkin's and non-Hodgkin's lymphoma. This is any sort of cancer involving the lymphoid tissue, right? So your lymph nodes and throughout. Hodgkin's is usually painless, okay, and it usually involves lymph nodes and the spleen. Non-Hodgkin's is like usually much more aggressive, lymph node, liver, spleen swelling. Patients or people who have had mononucleosis, especially if it's like repetitive mononucleosis brought to you by the Epstein-Barr virus, tend to be at increased risk of developing a lymphoma. Then you have multiple myeloma, which is cancer of the bones, the cancer of the plasma cells. But the plasma cells are, because it starts to accumulate in the bones, it starts to destroy the bones. It also creates a large amount of protein M, which affects how viscous the blood is. Increased viscosity of the blood, right, a little extra sticky, starts to impair tissue function. So you have patients who might have abnormal bone breaks, right? This is, could be, patient might have multiple myeloma and like never really notice until they break a bone doing something kind of that wouldn't otherwise break a bone. Polycythemia is increase in the red blood cells that are in the blood. This could be due to just abnormal, like idiosyncratic, like you just have too many red blood cells. It could be due to chronic hypoxia, so you see this in your patients with emphysema and chronic bronchitis. You also might see polycythemia in patients who are at elevated elevation, right? So patients who are who live in Colorado normally might have more red blood cells that would qualify as polycythemia. And dehydration. Dehydration is not true polycythemia. It's a reduction of the plasma that then brings the concentration of the red blood cells up due to loss of plasma. Most of the time, these patients will have like a ruddy red look to them, but there's all sorts of other concerns that usually kind of contribute. Most of the time, it's increased blood Thicker blood will lead to blood clots. Um, so that's always a concern because it increases the risk for MI and stroke. Um, your spleen gets a lot of damage in this department because remember, spleen holds on to red blood cells. So if there's extra red blood cells, it could become enlarged. Generalized itching, blood cells. All right, DIC. We generally in the field will not see DIC. This is something that pops up in like the ICU. Um, and if there's an episode of House that talks about DIC, it was a ballerina who had some issue and they saved her finger. So want to go watch that. It probably does a better job of describing what DIC is. But basically, DIC is an abnormal clotting disorder that's usually brought on by some sort of trigger. And the trigger is usually really bad trauma, really bad sepsis, like something really bad, okay? Like a severe stressor to the body. So what happens is your body starts freaking out and decides that we need to clot. Okay, we need to make sure that we're not going to die. We need to clot. So it just pretty much blasts the body with every single coagulation factor it has, and it starts making sure that we're not going to die from blood loss. The problem is it wastes all of the coagulation factors. It starts throwing little microclots everywhere. Okay, because now your blood's just extra sticky. You got these little teeny tiny clots popping up and around, and it ends up landing in things like your lungs, your head, your brain, your heart. Okay, the problem is you've now dealt with a trauma or sepsis and you're bleeding and you no longer have coagulation factors, so you're throwing clots while bleeding out. Okay, so DIC is a very hard to manage condition because you want to make sure that the patient's not throwing all these clots, but you also want to make sure that they're not bleeding. Um, the definitive treatment for DIC is fresh frozen plasma, which conveniently we don't carry. The hospital does. So, as I said, this is not something that you're necessarily going to be seeing in the field. You might be doing this as like a transport from one hospital to the other, but it's important that you kind of are familiar with the concept that it's your body's clotting and bleeding all at the same time. There's an algorithm for it. Again, doing D dimers in the field way more than the rest of us. All right, so hemophilia. Hemophilia is a genetic condition that is caused by a deficiency of a whatever particular clotting factor. It involves bleeding, excessive bleeding. The Romanov family, right? Anastasia, her younger brother, had a hemophilia condition. So if you look at the intrinsic pathways, this is your basic, rundown of how clotting happens, okay? So if you have hemophilia A, it's factor 8 is missing. Okay, so here on that blue is factor 8. So in order to get to the common pathway, you need factor 9 and factor 8 to team up and turn into factor 10. If factor 8 is missing or extremely deficient, you're never going to make it to the common pathway. Okay. Then you have factor 9, right? We just pointed that one out, is right above the blue. Factor 9 is hemophilia B. This is called Christmas disease. Don't ask why, I do not know. Which causes, again, you don't make it to factor 10, you don't continue moving down the pathway. And then you have von Willebrand hemophilia, which is the most common type of hemophilia. There is a missing or defective von Willebrand factor. It's very British slash German slash Austrian. And it fails to trigger your factor 8. So you're still dealing with that same, hold on. So you're still like kind of operating here as in your dysfunction area, but now you have von Willebrand, which is not even making factor 8 happen. So you're not getting, so it looks like hemophilia A, but it's due to von Willebrand. That makes sense. Other problems, thrombocytopenia. So let's talk about breaking that word down. Thrombocyte, right? Platelets. Penia is not enough. So when your patient starts to have a low platelet count, they will have spontaneous bleeding. Again, a lot of things nosebleeds, bleeding from the gums, very heavy menstrual flow could be a sign of this. It could be associated with a number of different issues, including leukemia, lymphoma, aplastic anemia, uh, vitamin B12 issues, a lot of the things that we've already kind of talked about. Massive blood transfusions, right? So if you have a patient who needed massive blood transfusions, sometimes the platelets get destroyed in that process. You'll see these petechia on the skin, petechia and purpura, which are like these like little red blotches of essentially they're like little bleeds, little teeny tiny bleeds in the skin. So it could be idiopathic, where the antibodies start destroying the platelets. It usually happens after an infection when your blood cells, your white blood cells are a little overenthusiastic. Or you could have thrombotic purpura, thrombocytopenic purpura, which is a lot of little small clots. This is usually associated with pregnancy, HIV, AIDS, some prescription drugs, cancer. You're not going to be telling the difference. Just know what the word thrombocytopenia really means. Oh, good. All right. Questions, thoughts, concerns. Beth looks like she's drowning in sand. We're losing Beth to the sand. The sand people are taking her. No? Good? All right. Let me see if I get you some stuff to review. And go from there. All right. Good luck. Make sure you read. Make sure you take notes. Study. And let me know if you have any other questions, okay? All right, guys.
So,